Good morning, everyone. Dr. Martin. Very nice to see you all again today. I know we touched on this in pieces, and I wanted to discuss this in a little bit more depth because conservatively 20 million Americans suffer with neuropathy in the United States on a daily basis. And these patients are coming to our practices. Very commonly in podiatric practices, we see them in primary care practices, we see them in pain practices, but they're spilling over into orthopedic practices and surgical practices and plastic surgery practices because this disease process is just so pervasive. This entire lecture is going to be based on, number one, my opinion, but number two, on the experimental application of allogenic biologics for a neuropraxic paradigm. Now, we're all familiar with the term neuropathy. Neuropathy is a disease state, and you cannot apply a human cell and tissue product to treat, diagnose, cure, or prevent disease. However, you can apply a human cell and tissue product, whether that's allogenic or autologous, for a cartilage-based defect. Now, we're not talking about treating neuropathy. We're not talking about treating a systemic disease process. What we're talking about is the experimental application of a human cell and tissue product for a cartilage-based defect in a nerve, right? And there are levels to everything. And so we're going to talk about those levels very practically. And again, this is all experimental. Now, what we're going to talk about is the application of umbilical cord tissue derived exosomes and Wharton's jelly, right? Now, I understand that exosomes are kind of a hot topic. They get talked around a lot. And there's a lot of excitement about the product, in particular based on its application for aesthetics. But we're talking about an experimental systemic application of an exosome. Now let's get into what a neuropraxic deficit is. Let's get into what neuropathy is at a scientific level. The nerve, as we all understand and know, right, is kind of like speaker wire. And that speaker wire has insulation around it. You have all of the axons, or the fibers of the nerve, innermost. You have three layers of structure that surround those axons. You have the endoneurium, you have the perineurium, and then you have the epineurium, right? And depending on degree of injury, right, we can have multiple levels of injury. Your most superficial injury is a neuropraxic injury. And a neuropraxic injury is an injury to the epineurium. And the epineurium is dense, irregular tissue. It is type 1 and type 3 collagen. It is very literally the scaffold that myelin attaches to. We understand that myelin is the kind of insulation that heaps up in mounds along the nerve, and there are gaps between those mounds of myelin. And information travels down the nerve by way of axoplasmic flow through what's called saltatory conduction. Literally, information jumps from internode to internode all the way along the course of the nerve. And this allows for the rapid progression of a depolarization and a nerve impulse to travel down the nerve. This would be like driving from Orlando to Miami and jumping every 4 cars in traffic. It's going to make that drive much shorter. Neuropraxia is specifically a cartilage-based defect. It's a defect in the outer third of the nerve that is dense irregular tissue. Patients typically experience numbness and some tingling. More significant degrees of nerve deterioration, whether by way of compression, by way of cutting, by way of chemical injury or toxic injury, involves deficits of the epineurium and perineurium, right? So you have neuropraxic injury. This is called neurotmesis. Injury to the epineurium and perineurium. When you have damage to all three, the epineurium, the perineurium, and the endoneurium, this is called axontomesis. This happens when you've severed a nerve, when you amputate an extremity, that's either, traumatic or it's planned based on lack of blood flow or something like that. Now, if we've got complete damage of epineurium, perineurium, endoneurium, pretty much all bets are off, right? We're not talking about using the application of biologics in that paradigm. We are specifically not talking about neuropathy, a disease state with systemic issues. We're talking about specific neuropraxic deficits of peripheral nerves. Which is a mono-neuropraxic deficit. Specifically, it is not a mono-neuropathy, it is a mono-neuropraxic deficit. That's what we're speaking to. A deficit in the outer third of the nerve in the across elbow segment, in the across wrist segment, in the across fibular head segment, in the across tarsal tunnel segment. That's what we're referencing. And you can see I wobble a little bit when I go on one foot. I've got a bad low back, and it actually knocks out on occasion when I've done too much road biking or working out, it knocks out my gluteus medius. And so my ability to stand on my right leg wanes occasionally. So if you see me limping every now and then, well, I can join the club because I've got a terrible back. Now, let's get into what's a potential application, all right? And then we're just going to talk about tarsal tunnel syndrome at this point in time, and more specifically, a mono-neuropraxic deficit of the tibial nerve in the across tarsal tunnel segment, right? Something very commonly seen in podiatric medicine, something very difficult to treat. So we have a foot and ankle. We're going to try to do this in black, all right? Here is your heel. We come down. This is the medial aspect of the ankle, so this is going to be big toe, right? And then all of our other smaller toes coming back up. Not the prettiest ankle, but we all understand. Basically, this is what we're looking at. Here is the medial malleolus, right? The tarsal tunnel lives about here, all right? If you break the foot up into vectors where you've got north, south, east, and west, and your toes are pointing at, say, 12 o'clock in 6 o'clock, right? This is 6 o'clock. This is 12. This is 3. This is 9, right? At about the 5:30 position is the tarsal tunnel. It is about right here, right about 5:30, all right? And the tibial nerve courses down the back of the leg, goes through the tarsal tunnel, and splits into 3 branches. Splits into the calcaneal branch, splits into the medial plantar branch, and it splits into the lateral plantar branch. The calcaneal branch subserving sensory distribution on the plantar aspect of the heel, the medial plantar nerve subserving plantar sensation in the medial aspect of the foot, the lateral plantar nerve subserving sensory distribution to the lateral portion of the foot. All right? Now, if we have a compression across the tarsal tunnel and we have numbness and tingling in the bottom of the foot, and assuming that that is due to a patient that has pronation, they have collapse of their medial arch, their spring ligament has collapsed, transverse ligament may be collapsed, and so they pronate. Well, pronation tends to put forcible pressure on the tibial nerve in the across tarsal tunnel segment, which can lead to a neuropraxic deficit and numbness and tingling in the bottom of the foot. Now, certainly we want to put the foot in forefoot neutral, and so arch supports would be great. A UCBL might be great, but assuming that those things fail, we've tried putting the foot in forefoot neutral, it doesn't work. Maybe we've tried a cortisone injection in the tarsal tunnel, that was not effective. We've tried gabapentin, we've tried Lyrica, maybe we've tried over-the-counter NSAIDs, those have all proven ineffective. And so we are pre-surgical, where the decision is, okay, we have one of two options, right? We've exhausted conservative measures, and we have kind of two choices. One choice is the experimental application of an allogenic biologic to this cartilage-based defect of the outer third of the nerve. The other is to do surgical exploration and to resect the tissue that creates the roof of the tarsal tunnel and potentially decompress the tibial nerve as it courses through that space. We're assuming we're not doing surgery, right? And so if we were to apply something like a Wharton's jelly product, what is Wharton's jelly? Well, histologically, Wharton's jelly is type 1 collagen, a little type 2, type 3, 5, 7, 9, but also hyaluronic acid. That cartilage-based defect of the nerve, that neuropraxic deficit, mono-neuropraxic deficit in the tibial nerve as it courses through the tarsal tunnel is a deficit of type 1 and type 3 collagen. Is it appropriate to apply a growth factor complex that has type 1 and type 3 collagen and some hyaluronic acid to that defect? It is. All right. Now, practically, how do you do that? Well, at this 530 position, the tibial nerve is rather superficial. And so we would not just go fishing for the nerve. All right. Ideally, your application is a subcutaneous application, and you're filling this region with biologic. Understanding that we're putting in collagen-based growth factors so the body can go through its own process of cellular repair. And ideally, we've provided the necessary collagen growth factors so the body can go through collagen differentiation. Now, assuming that the body goes through collagen differentiation, is there a possibility that the patient's numbness and tingling will clinically improve? Well, we've already stated that myelin is absolutely essential for propagation of impulses down myelinated nerves, right? And we've already discussed that myelin only attaches to scaffold. It doesn't attach to the perineurium. It will not attach to the endoneurium. You have to have intact epineurium. You have to have microarchitectural scaffolds for myelin to attach to. So if the body does go through that process of collagenic differentiation, and we do get collagenic scaffolds in the epineurium, is there a likelihood that we will get remyelination of that nerve? Yes. These are 3 fantastic references. Below this post, I will show these. All right, 2 of these are from neuroregenerative research. This one in 2012, this one in 2015. This was the application of umbilical cord-derived biologics for crush injuries of the sciatic nerve. This is a more peripheral application to a peripheral nerve of, again, umbilical cord-derived tissue. This is rat model application systemically of umbilical cord-derived structural growth factors to look at the systemic paracrine effect of those growth factors in whether or not they facilitate collagenic differentiation and remyelination. And they found this to be the case in rat model. This is a fascinating article. Again, I will reference these in long form so that you can look at these. Clinically, how would you go about this biologic application from an experimental standpoint? The crux of that relies on you actually documenting outcomes, objective outcomes for the patient. First and foremost, prior to doing any of this, you want to pretty aggressively record all the things that have failed, right? Number 2, you want to pretty aggressively document what the patient experiences and feels and where, right? Now, from an objective standpoint, you can do monofilament testing, which I believe is absolutely essential, all right? Your diagnostics that are objective are twofold. Number 1, monofilament testing. You can buy a monofilament on Amazon. It's dirt cheap. It's all of about 15 bucks. Number 2 is nerve conduction velocity testing across the tarsal tunnel. I would do both monofilament testing and nerve conduction velocity testing prior to any allograft application. This is not going to suddenly go back to normal after a single application. It's going to require 2 or 3 applications. Typically, what I have seen talking to other providers who are doing this experimental research is your applications are at 0, 6, and 12 weeks. 3 applications, 6 weeks apart. Where monofilament testing and nerve conduction velocity testing is done prior to the first application and after the third. Where monofilament testing is done before every application at 0, 6, and 12 weeks. Okay? Again, nerve conduction velocity testing and monofilament testing done prior to the first application, after the last application. Monofilament testing done at every application, 0, 6, 12 weeks, all right? Because it's simple, it's easy, and it's fast to do. I put exosomes on this board. Why did I put exosomes on the board? We are again talking about experimental application. And if we look at a paradigm like tarsal tunnel, where we have a mono-neuropraxic deficit, if this deficit is in the setting of somebody who has a toxic neuropathy, diabetic neuropathy, other inflammatory or viral illnesses that might have either made this compressive deficit worse, meaning a 2-hit hypothesis, right? 1 hit, viral, inflammatory, systemic hyperglycosylation, systemic disease process, injury to nerve number 1, compressive pathology across the tarsal tunnel, pathology number 2. All right? Is there a role for systemic application of an exosome product to systemically down-regulate inflammation? I believe it's an option. All right? Are we treating neuropathy? No. We're essentially using a more potent systemic allograft, not to treat any disease, but to activate microRNA, stimulate M2 macrophages, upregulate ARG1, upregulate IL-10, downregulate IL-1 beta, and ideally reduce inflammation. Now, any of you that have talked to me, I talk about going out to dinner. Let's say for Mother's Day, because that's coming up. Now, assume you are at dinner with your spouse. It's Mother's Day. You sat down at a beautiful steakhouse or vegan restaurant, whichever you prefer, right? And your plate is served. It looks gorgeous. There's a fabulous bottle of wine there, and you're just about to take your first bite. And one of your exes walks up and plops down a chair and a seat right next to you and starts unloading on you, all right? I don't care how good the meal is. I don't care how great the restaurant is. I don't care how much the wine cost or how wonderful a vintage it is. I don't care how much you've had. That is going to be a terrible meal because your ex is there hammering you, right, and stressing the environment. That's what inflammation does. Inflammation is a systemic and constant and pervasive stress in an already stressed environment. Can you potentially improve clinical outcomes on an experimental basis using a systemic application of an autologous or allogenic exosome product to down-regulate inflammation? There's potentially a role. And there is some literature, very good literature, in particular on allogenic exosomes down-regulating inflammation. And again, I will link that article below this lecture, kind of in the asset list for this lecture. And so if you were to do that, if you were to apply a biologic, not to do anything other than down-regulate inflammation, potentially provide immune support, I would do that 2 weeks before any initial application of a biologic, focally in the region of a mono-neuropraxic deficit. Now, this is obviously very experimental. I would strongly recommend, if you're going to use this protocol, either with or without exosomes, that you are tracking outcomes, that you are using monofilament testing, that you're using nerve conduction velocity testing. For 2 reasons. First and foremost, if we're going to do experimental work, we should actually collect data, right? But number 2, and most importantly, if you've collected data on your patients internally in your practice, you know how these applications are working. And as opposed to making some tall promise or I'm going to wave the stem cell magic wand and you're magically going to get better, which I think is a total farce, you can speak objectively to a patient's outcomes and you can say, well, I've had 7 patients that have gone through this experimental paradigm, and we've seen a 42% improvement in monofilament testing, a 35 to 40% improvement in nerve conduction velocity in the across segment, and that has correlated with the 40-45% improvement in clinical symptoms. That's significant. Remember, placebo's 30% improvement. For over 20 years, not a single study demonstrated that long-term narcotic use improved patients better than placebo. And there are quite a number of providers on an experimental basis using a very similar protocol and achieving 40 to 45% improvements in monofilament testing, nerve conduction velocity testing, and correlated patient symptoms. That is very, very significant and potentially life-changing. Anyone suffering from constant numbness, tingling in the feet is like walking around all day with your ex-spouse or ex-boyfriend or ex-girlfriend railing you, bickering, nagging, screaming at you in your ear all day, every day. It doesn't stop. These patients constantly suffer. They all have very elevated stress hormones. They all have very elevated stress responses. They have dysregulation in hormones. They have dysregulation in immune response and humoral response. They have elevated cortisol levels, elevated blood sugar levels, elevated SED rate, CRP, complement levels. These patients are suffering. And even though it's just numbness and tingling, I would suggest to all of you who don't have this, I want you to just take a rubber band. And I want you to put a rubber band around your wrist that's a little too tight. And I want you to wear it all day, every day for a week without ever taking it off. See how much of that you can endure. I would venture to say that most people, after about 5 or 10 minutes, are going to take that off and be like, all right, I get it. These patients don't have the ability to take off the mono-neuropraxic deficit or the systemic deficits. They don't have that ability. And if they failed all other conservative options, there's no guarantee that surgical decompression is going to work. So do I think it's reasonable to try the application of allogenic biologics and see if we can improve their outcomes and we can improve their quality of life? I think it's perfectly reasonable. I'm Dr. Martin. Have a very blessed day.